Good evening, friends. Welcome back to the Tuesday sessions of Critical Care and Emergency. This has been a regular sessions run by Yashoda Hospitals as a group. We are going through an unprecedented pandemic, but we decided the streamlines should go on, the life should go on. This became a new normal, and this new normal became a year old or more than that. Today, we have some interesting topic to discuss. For last probably few months, we were listening about a stem cell transplant here, there in the so-called Western countries, developed world. And there were also rumors, reports, informations that there are few case reports where these stem cells has been used in India also. We have Dr. Ganesh Jaishetwar, who is our senior consultant and head of the department hematology and bone marrow transplant. He has his MD and DM degrees in hematology. Added to that, he has many fellowships to his account. He will probably enlighten us today on the role of stem cell transplant and other hematological and clotting related disorders in COVID. Many of our clinicians had many doubts in mind. Last 1 year has been a doubtful year for every treatment here and there. So remdesivir, steroids, and anticoagulant being the first line therapy, there are many experimental investigational therapies, including the plasma, including different immunomodulators, including some inflammatory suppressors, and many more. So listen to stem cell transplant and other hematological issues. Now I will request Dr. Ganesh to enlighten us. Over to you, Dr. Ganesh.
Thank you so much, sir, for the kind introduction. Good evening, everyone. At the outset, I would like to thank our Yashoda Group of Hospitals for bringing all of us together on this virtual platform, and I'm thankful for this opportunity. So, COVID pandemic, second wave in particular, has been very, very devastating compared to the first wave. And this talk is in fond memory of my mother, whom I lost recently to the second wave of pandemic. At the same time, I would like to, dedicate this talk to all the heroes, the real life heroes who have lost their lives battling the mankind against this devastating COVID pandemic. So this particular cartoon has been very, very making a huge appearance on various social platforms. So this is kind of my disclaimer also. This is by Damian Barr, a famous columnist, depicting the current ongoing COVID pandemic, the unprecedented second wave. So we are all, even though we are all not on the same boat, but we are all in the same storm. So being a hematologist, I'll try to put my thoughts and the available literature in managing the hematological issues associated with COVID pandemic. So as we speak now, when I was checking the facts about the second wave, the numbers across, it's a tickling bomb across, not only in our country. India probably has the second highest affected personnel with this COVID pandemic overall, with total cases exceeding 20 millions, of which almost 222,000 casualties losing their battle against this COVID infection. Whereas across the globe, as we speak today, there are more than 150 million cases worldwide, and of which about 3.2 million is the case fatality rate across the globe. So it's a burning issue, and we are all going through the most devastating second wave of this COVID pandemic through these unprecedented times. So treating COVID-19 amid such serious calamities, casualties, what works and what doesn't is an important issue. Although the India has its first case of COVID-19 in 30th of Jan 2020, it's more than almost just above a year, but I'm sure you will agree with me, this pandemic over more than a year looks like more than a lifetime. And there has been an exploding literature on COVID-19. As I just checked the facts on COVID-19primer.com, as we speak, there are more than 100 37,000 papers on COVID-19 over just above a year. And to be more precise, more than 2,000 papers just over last 7 days. So in a way, I won't be wrong telling that this is COVIDization of the research in medicine. So with all the exploding literature in COVID-19 and its management, most of the therapeutic interventions suggested or devised by various expert panels or various groups across came from the initial observational studies. But the initial promise in those observational studies is literally dashed for many therapeutic agents when all these agents, either alone or in combination, were put to the rigors of randomized controlled trials. And one of them is mesenchymal stem cell therapy, which I'm going to touch base in today's brief discussion. So coming to the first topic of my presentation, COVID-19 coagulopathy, peculiar over last more than 150 million cases, what we have observed, many cases presents with mild thrombocytopenia with mild elevation of PT. An elevated fibrinogen as an acute phase reactant, peculiar to any inflammatory or infectious process, is again a common phenomenon in COVID-19 infection. And what is more peculiar is elevated D-dimer, which poses the increased risk of thrombosis in moderate or severely affected COVID-19 patients. Although overt DIC with hyperfibrinolytic or bleeding phenotype is rare and kind of develops in the late stages of the disease, but thrombosis is the major manifestation of the COVID-19 severe infection. Now, why does the use of anticoagulants on such a high rise, and literally everybody across, whether it is primary care setting, secondary or tertiary care setting, anticoagulants are of wide use. One thing which has been undoubtedly, undisputedly proven to be of huge benefit in saving the lives of these severely affected COVID-19 patients is anticoagulants. Now, the preliminary evidence came from the autopsy series from across many regions, and this is one of the series from New Orleans, cardiac and pulmonary pathology in African American patients. And what they found, you can see on this diagram here, apart from the larger vessel thrombosis, thrombotic microangiopathy involving small vessels of the lung is a pathological hallmark of severe COVID-19 infection. So in a way, COVID-19 is a serial killer, no doubt. It has two bullets, the one on the lung and the second one is on the vascular side. Most notably, disseminated thrombotic microangiopathy causing extensive lung involvement, leading to severe respiratory failure, many times to refractory respiratory failure with increasing oxygen requirement. And that has been the pathognomic sign of COVID-19. And that's what we are hearing last couple of months across the country, where our, the lawmakers, the politicians, the bureaucrats are busy campaigning for the elections across, and the whole country is shaken with the scarcity of oxygen because of the extensive lung involvement in most of the cases during the second wave of the pandemic. Now, if you look at the burden of thrombosis, again, these are observational retrospective studies, mostly from the ICU population from various countries. You can see here the incidence of thrombosis, venous thromboembolism, ranges from somewhere between 16% to 69%. And you can see the third one from the France in 26 patients who were studied where the screening was done. So, the more you look for it and the more you will find it. So in this protocol, in this France, this third study, all these patients underwent as a protocol routine screening of the limbs and the lungs for the evidence of thromboembolism. And you can see there the incidence of clinically diagnosed thrombosis was 70%. So such is the magnitude of this problem. And the lab predictors of thrombosis as from various studies has been found that the inflammatory markers like ESR, ferritin, CRP, and the thrombotic markers like D-dimer, fibrinogen go parallelly together. And all these markers, you can see the p-value for all these markers, both inflammatory and thrombotic markers. They have predictive value for thrombosis. So that indirectly signifies that the thrombosis and inflammation goes hand in hand. So this is peculiar of COVID infection, the endothelitis, the endothelial inflammation. So the COVID infection causing inflammation of the endothelial lining, leading to thromboinflammation, right? So the endothelial lining has inherent antithrombotic and anti-inflammatory properties. And with the disruption of this endothelial lining, there is predisposition to inflammation as well as thrombosis. So this term, new term, thromboinflammation, coined and has been emerged in the cases with severe COVID-19 affliction. Now, microvascular thrombotic and inflammatory response, as I mentioned earlier, the endothelial dysfunction, endothelial disruption leading to thrombosis as well as widespread inflammation underlies the major etiological presentation of severe COVID-19 infection. And again, from the autopsy evidence across various studies, this is again one study from Dr. Wichmann et al. From Germany. It's a prospective study. You can see of 12 patients whose autopsy was done, had of these more than 50%, like 7 out of 12, unsuspected bilateral DVT, which was discovered on autopsy finding. And of 7 patients, 4 out of 7 had died from extensive pulmonary embolism, which was unsuspected prior to these patients' death. And 6 out of 9 men had, in this study, had fresh thrombi in the prostatic venous plexus. I just wanted to, trying to highlight the extent of thrombotic manifestations in severely afflicted COVID-19 infection. So, like the famous Telugu cinema suspense Vaikata Bakil Bahubali, fetching highest reviews for Bahubali 2. And these studies, observational as well as retrospective studies, has improved our understanding of the major the adverse outcomes in these patients. And based on this, the International Society of Thrombosis and Hemostasis has put before this anticoagulation algorithm. So anybody getting admitted with COVID-19 infection, so hospitalized patients, moderately severely afflicted hospitalized patients, does need prophylactic anticoagulation. And if the D-dimer, prothrombin time, platelet count, fibrinogen levels, based on these markers, you can decide the extent of anticoagulation required in these cases. Again, this is simplified version. The COVID-19 criteria for severity, you can see the severity criteria is respiratory rate more than 30 beats per minute, arterial oxygen saturation less than 93% at rest, the PO2 ratio less than 300, and radiological evidence of extensive lung involvement covering more than 50% over 1 to 2 days, progressing over 1 to 2 days. And this is again ISTH SIC score, severity of illness score based on platelet count, INR, and SOFA score. So based on these, you can devise the anticoagulation, the extent and intensity of anticoagulation. Again, for patients with mild or moderate infection, standard prophylaxis, and patients with severe infection, full dose anticoagulation. And again, one of the other parameters, the renal impairment, you can decide the choice of anticoagulation. Again, there are various protocols, algorithms across the literature. This is the simplified version I found on the literature. Emory University recommendations from North America. You can see based on the 2 simple parameters, the D-dimer and evidence of overt venous thromboembolism, you can divide these patients into 3 levels. The level 1 is the D-dimer less than 3,000 and with no evidence of any overt thromboembolism. The handle thromboprophylaxis which can extend 1 week post-discharge. Whereas level 3 is more than 3,000 D-dimer with evidence of venous thromboembolism. They require therapeutic anticoagulation, which needs to be extended for 3 months post-discharge, just like any unprovoked DVTP. And the level 2 is D-dimer more than 3,000 without any evidence of overt thromboembolism, which fall into intermediate category. Again, these patients, as a recommendation, may vary based on different societies, but normally, as per this university recommendation, 4 to 6 weeks post-discharge anticoagulation continuation is recommended. Now, what do other guidelines say? As I mentioned, the post-discharge, different guidelines mention different, but some amount of anticoagulation depending upon the severity and the serial D-dimer levels can help us divide the anticoagulation, extent of anticoagulation, duration of anticoagulation. One important factor here is non-hospitalized patients. As per the NIH guidelines, all non-hospitalized patients with COVID-19, anticoagulants or antiplatelets should not be initiated for prevention of venous thromboembolism or arterial thrombosis unless and until there are other valid indications for such anticoagulation. So the learning points for anticoagulants must be used for all hospitalized patients except the mildest infection ones. Again, it has to be guided by D-dimer levels and evidence of overt thromboembolism. Low molecular weight heparin once a day or twice a day is a common preferred anticoagulation in the hospitalized patients. Considered direct oral anticoagulants like apixaban for 3 weeks minimum in moderately or severely afflicted patients, particularly where D-dimers continues to remain high. Now, switching gears further, one of the important and most talked about topic in COVID-19 management, particularly in the very severely affected patients, rapidly deteriorating, is the role of mesenchymal stem cell therapy. Whether it is a hype or real promise. Of course, the first pilot study way back in last year, April 2020, allogeneic stem cell therapy by Mesoblast, an Australian regenerative medicine company. Their product name is REM stem cell L, and this was studied in two of the New York hospital, Mount Sinai and the Presbyterian, in April 2020. Here, what they found in the initial pilot study that for moderate to severe ARDS, the survival was 83%. That means 10 out of 12 patients survived, those receiving mesenchymal stem cell, this REM stem cell, whereas for patients not receiving out of 320, only 38 survived. So the survival was quite significantly better in those receiving this MSC, 83% versus 12%. Again, successful winning of ventilator was 75% in those receiving REM stem cell versus 9%, that is 38 out of 445 with a median of 10 days. So this was a very, very promising, exciting study. And based on this, in fact, Novartis took over Mesoblast with a historical deal of $1.2 billion. But subsequently, however, the initial promise, as I mentioned earlier, could not sustain in phase 3 randomized controlled trials done across USA. Where the preliminary reports were published in December 2020. It didn't show such remarkable superior outcomes in patients receiving REM stem cell. So even now there are many trials going on. So we have to think differently for severely afflicted COVID-19 patients. The potential mechanisms of MSC, mesenchymal stem cell therapy, is not new to hematology and bone marrow transplant. We have been using it for last two decades for patients with steroid refractory GVHD, and the rationale for mesenchymal stem cells in severely afflicted COVID-19 infection remains the same. How does it work? It has immunomodulatory and tissue reparative regenerative properties. And how does immunomodulatory properties? This is based on upregulation of the protective cells like Tregs, Bregs, regulatory dendritic cells, and M2 macrophages, and down regulation of the inflammatory mediators which underlie the major inflammatory damage cytokine storm in severely afflicted COVID-19 patients. And these are the suppression of plasma cells, effector T cells, NK cells, mast cells, neutrophils, and M1 macrophages. So there is a lot of diversity in the mesenchymal stem cell origin and variability of the dosages, schedule of administration, and route of administration that probably explain the various heterogeneous results reported by various groups across. The initial promising results could not be reproduced across the couple of randomized controlled phase phase 2 randomized controlled trials because of all these factors. Now, we all know mesenchymal stem cells can be derived from bone marrow or placental tissue or adipose tissue. And there are a lot of factors which determines the quality of the product. Cell isolation, expansion, biobanking needs to be done in GMP certified facility. And the product delivery, again, the route of administration, intrathecal, IV, intramuscular, subcutaneous, a lot of heterogeneity. Probably that might explain to some extent the heterogeneous results observed by various groups across the globe. Now, looking at the clinical trial going on, still going on with mesenchymal stem cells, you can see this is the slide. I got it from the US site. You can see the number of clinical trials for mesenchymal stem cells from 2011 across, particularly in the transplant, steroid refractory GVHD, as well as refractory viral infections, has been on rise year by year. And particularly for the second, the down curve, the bar charts are for COVID-19 infection. You can see initial surge in April, but now the number of the trials are weaning off. And there are exceptional couple of phase 3 trials with not so encouraging data. And you can see the source of on the right hand, you can see in the pie chart, the source of stem cells, the countries where these stem cell trials is being done. And these are the published clinical trial data with mesenchymal stem cells for severe COVID-19 infection. You can see various sources, various dosages, various frequencies, and various phases. So, in nutshell, it is not yet proven to be of solid or robust benefit in severely infected COVID-19 patients. So, based on this is NIH recent COVID-19 treatment guideline. You can see cell-based therapy under evaluation for treatment of COVID-19, and this is last updated in April 21, 2021. So the recommendation is COVID-19 treatment guidelines panel recommend against the use of mesenchymal stem cells routinely for treatment of COVID-19, except in clinical trials. And this is a recommendation. So that's why still the regulatory authority approval for COVID-19 is not on board. So I must say, for placing knowledge above wisdom and science above common sense, my God, my good Lord, forgive me. I know a lot of people have a lot of hopes on this MSC therapy, particularly in the refractory, rapidly deteriorating, severely affected COVID-19 patients. But yes, the scientific studies, more scientific studies, mostly the randomized controlled trials is the way to address whether it is really going to be of that promise as it was erupted with the pilot study way back in April 2020. So just brief about COVID-induced, COVID vaccine-induced thrombocytopenia. Again, this is ISTH, International Society of Thrombosis Hemostasis guideline. Basically, the treatment revolves around steroids, IVIG, and in the refractory cases, plasma exchange, just like IT. But before that, you can work up these cases with PF4 antibodies and other pertinent investigations appropriately. Switching gears further, last part of my talk, the common hematological abnormalities. Is it from COVID-19 infection? A brief synopsis. The commonest is lymphopenia. You can see the initial results from China. Almost 70% patients have lymphopenia. These are all retrospective trials, retrospective studies. Not only the lymphopenia was a common, observational finding, but the degree of lymphopenia also correlated with the adversity of outcomes. So downtrending absolute lymphocyte count correlated with the adverse outcomes and death in many patients. Now, second, besides thrombocytopenia, is thrombocytosis seen in less than 5% cases, and thrombocytosis seems to coincide with inflammatory state. My apologies, thrombocytosis is a common manifestation across less than 5% cases present with significant thrombocytopenia. And the reason of thrombocytosis mostly being an platelet being an acute phase reactant, just like hyperperemia, it coincides with the inflammatory state. Again, thrombocytopenia should prompt further evaluation. AKI is common, but contrary to our common flag sign alert like AKI with thrombocytopenia for any physician or any hematologist, the first alarming differential is thrombotic microangiopathy like MAHAT, microangiopathic hemolytic anemia, thrombotic microangiopathy, TTP-HUS. This is not so commonly reported across the various severity of COVID-19 infection. So thrombocytopenia as a routine manifestation of severe COVID-19 infection in constellation with AKI is common without thrombotic microangiopathy. Again, anemia, variable rates, most have normal or baseline hemoglobin. Common possibilities of the common etiologies are anemia, chronic disease, bleeding. The patients are on active oral anticoagulation, need standard evaluation. And the most important factor in such patients with anemia, elevated ferritin and LDH as a marker of ongoing inflammation may confirm the workup of anemia. So before I conclude, I would like to put before this famous, saying by Charles Darwin way back in 18th century. It is not the strongest of the species that survives, not the most intelligent one, but the one most responsive to change. So we should change. It is a time for us to change to have a better chance of survival across the COVID-19 infection. And the best chance of protecting ourselves from COVID-19 infection, I like to put before this cartoon, the Black Plague doctor of 12th and 11th century across Europe. You can see the doctor with this fancy PPE, with the fancy face mask with the shape of bird beak because the mask used to be stuffed with flowers and scents to protect them from the nasty smell of you can see the dead bodies lying in the coffin lying around. So these same principles of any epidemic management, stay home, stay safe, maintain the distance, is putting a stick on his hand to maintain a safe distance, and again the same placard urging the people to stay home. It's 8-9 centuries have passed by. The management of pandemic like COVID-19 essentially revolves around the preventive measures of protecting ourselves. So with that, I would like to thank for the patient hearing and hoping and praying for the safety and well-being of you all across. And I will be happy to answer if there are any questions and if the time permits. Thank you.
Yeah, thank you, Dr. Ganesh, for that enlightening session. I think there are many actually questions related to more of stem cells. There is a lot of interest because many clinicians yet to get first-hand experience on that. So to start with the discussion, what is the dose of the stem cell which generally has been used in this COVID pandemic during the last year or so in different studies?
Sir, as I mentioned earlier, the heterogeneity in the studies based on the source of mesenchymal stem cells, the dose varies from 0.5 million to 5 million per kilogram of the patient body weight. So depending upon the various products, various sources of these products, various companies producing these products, the doses are variable. I like to mention here that the mesenchymal stem cell utilization across our country is on a very high rise. We wanted to utilize mesenchymal stem cells as a pivotal study in few of our very sick COVID-19 patients. To our surprise, we found out that the utilization across the country is so high that most of the mesenchymal stem cell manufacturers are their products, their storage is exhausted across the country. So a lot of centers are utilizing it. Probably it is high time for all of us to put together our efforts and put together all the efforts together on paper and see how much for our patient subset this stem cell product can work. One thing is important here. Being a transplanter, we have used mesenchymal stem cells for many of the graft versus host disease. The graft versus host disease, the overall manifestation of graft versus host disease post allogenic bone marrow transplant, the overall presentation is very much similar to severe COVID-19 infection. So there, the uncontrolled inflammation, the donor lymphocytes attacking the patient body, and leading to uncontrolled cytokine storm. And that cytokine storm is damped by these mesenchymal stem cells. So from our experience in GVHD, if not beneficial to that extent, they are not so harmful also. So I personally believe and feel there is in desperate non-responding patients, these patient subset need a trial of these kind of cellular therapeutic intervention. And probably we should all put our efforts together to see how much of the benefit can be derived from such cellular therapeutic interventions.
So we focus on that dose which you spoke about, a 0.5 million to 1 million per kilogram, is it only a single dose? We need to repeat
So
the dose.
again, the dosages are variable. People have tried from 2 to 5 dosages at a interval of 3 to 5 to 7 days based on the response. And because they dampen the cytokine storm already happening in the lung, so those patients with refractory respiratory failure, increasing oxygen requirement despite all the supportive and therapeutic interventions, probably there the result should be apparent within 24 to 72 hours. I'm sure all of you might be listening a lot of hearing about and WhatsApp, WhatsApp messages across that it is being used in this state, in this city, with promising initial results. So, of course, it has a potential. Looking at the scientific rationale and the logic behind utilization of these products, it does has a potential, and it does has a definite scientifically proven rationale for utilization in severe COVID-19 infected patients. But yes, we have to put together our efforts to know how much of its benefit can be derived for our subset of patients.
Dr. Ganesh, we understand that we have a theoretical logic, we have a theoretical hypothesis that it will help in a storm like what we generally see a cytokine storm happening in different other clinical contexts. But we need to prove it with a clinical experience in COVID-19 patient in our setups. That's what we are looking at. With your current experience, if we consider the dose of 0.5 to 1 million units per kg in a maybe 2 to 5 doses or a 2 to 5.
Sir, what we are trying is a dose of 2 million per kg repeated for maximum of 2 doses at a gap of 3 days.
Okay. Let us fix that dose. If considering one dose, what will be the cost? There are many audience which are wanted to know what will be the cost, what is the source of them, where do they get them? As you already said, there is already a short supply of this, there is already a rise demand, supply issues and all that. But if at all we need to get, how do we get, who is the person to be involved in that, as you are expert in this field? So as a clinician from the critical care perspective, if suppose I wanted to try this stem cell therapy or mesenchymal stem cell therapy, whom do I contact? And what is also in the perspective of the patient selection, as you repeatedly told us that the patients who are refractory to the standard of care, what will be the timeline? Suppose we see a patient is initially on oxygen, then once we actually they'll end up into a mechanical ventilator with invasive ventilation and onto organ supports, then we see the outcomes go haywire low. So what will be the right time, right patient, and what will be the cost of these therapies?
Sir, thank you for bringing out those questions on this platform. So basically, sir, the how the mesenchymal stem cells are manufactured. It's a cellular therapy product. So either from the bone marrow, umbilical cord blood, placenta, or from the adipose tissues, healthy voluntary donors, mesenchymal stem cells are collected. They are expanded in the laboratory. Their quality is repeatedly checked, and after all the process of checking quality periodically, their dosages is decided based on the various quality and quantity parameters. So we as across the Hematology and Bone Marrow Transplant Society, we are used to utilize the products from Miltenyi Biotech. This is a biopharma company from Germany, and they supply us off the shelf all these cellular therapy products. So you don't need blood group matching. You don't need, these are allogenic donor mesenchymal third party mesenchymal stem cell product. It comes off the shelf, and based on the dose calculation, it can be infused with just simple some pre-medications to avoid infusional transfusion reactions and precautions to avoid the volume overload, because most of these patients are already with compromised lung. So to our logic, or what is mentioned across the globe, is the utilization of MSC product earlier in the disease course, before the lung damage becomes irreparable. When the cytokine storm is exploding, all the inflammatory markers are rapidly shooting up, patient is rapidly deteriorating, progressive refractory respiratory failure, increasing oxygen requirement. So earlier the intervention, probably better are the outcomes. So that is one aspect. And I would like to point out here one important thing. The important aspect of COVID-19 management is what is true today may not be true tomorrow, and what is false today may be at tomorrow's truth. Like we remember that with regard to steroids, WHO has made a statement way back in April, May 2020 that steroids are absolutely contraindicated across all severities of COVID-19 infection. They made a 360 turn back, and again after the Oxford the publication, UK collaborative group publication published in NEGM in October 2020, steroid has the preferred, if you look at the COVID-19 management, what actually exactly works, there are very few things.
Got it, Dr. Ganesh. I will just point out in view of time, what will be the cost?
The cost is, sir, base cost is dependent upon the dose. So average cost of mesenchymal stem cell product per million dose varies between 1,500 to 3,000. So for example, we have a 50 kilogram patient. He will require, by our, the Miltenyi Biotech product, 2 million units per kg dose. So for 50 kilogram patient, 100 million mesenchymal stem cell dose will be required. The cost will be around somewhere between 1.5 to 4 lakh rupees per dose. So maximum 2 dosages. So cost will be somewhere between 3 to 8 lakh rupees.
Okay, the cost varies between 3 to it's an expensive deal, but the cost varies. What is the common source? You said 3 sources: marrow, and then you said cord blood, and the third one is adipocytes. What is the common source you get?
The common source is placenta, umbilical cord blood, mesenchymal stem cell, because it is discarded product readily available. And second commonest source is the bone marrow collection from the healthy donors. And these cells, we don't require to collect a huge volume of bone marrow, because these stem cells are expanded in the laboratory, GMP certified laboratory, to get the requisite dosing.
Patient's family and patient's consent. So it's as you said, this is a stem cell. How do we explain what is the consents required?
So being an experimental product, not having any regulatory health authority approval across the globe, we need to be clear in our counseling that this is an experimental product being utilized based on the various trial data across the globe. Small case series trial data, it shows some benefit, needs to be explored as one of the desperate measures in rapidly deteriorating patients.
Okay, there are questions like, is there any role of autologous mesenchymal stem cell therapy? Can we use autologous ones?
In a very sick patients, I'm not sure, and there is no literature evidence of autologous stem cell, bone marrow being harvested from these patients, and these the same stem cells. So you need to get the mesenchymal stem cells in the bone marrow are not in the dosages which we require clinical. So they need to be manipulated, they need to be expanded in the ex vivo laboratory, ex vivo environment in the laboratory. So I'm not sure of autologous stem cell, mesenchymal stem cells being used, and there is not much of a literature evidence of autologous stem cells and the utility of autologous stem cells because the patient is already sick and most of the organ systems are already affected. COVID is a multi-systemic disease, and so the utility of autologous mesenchymal stem cells, I'm not.
What are the industries or companies who actually manufacture them and or which produce them and sell in India other than you named one company?
So there are many biopharma companies which are manufacturing, like Reliance, Milteni Biotech is the largest company providing all these cellular products. Reliance, Biocon. I'm aware of only handful of companies, but there might be many companies. All the commercial companies storing the umbilical cord blood stem cells might have the potential to manufacture mesenchymal stem cells.
There are other questions also like acceptance. Again, I think the same thing, convincing and acceptance related to the stem cells therapy were the questions. What are the adverse effects? You even the pointed out the adverse effect in your clinical experience are nil or what are the common adverse effects expected?
Yes, mesenchymal stem cell, the common adverse events are infusional toxicity, volume overload, and it also has a theoretic adverse effect profile of worsening the inflammatory cascade, worsening the lung function. That is postulated but not documented across various studies as well.
Okay, the other question is there were which stage of the disease? I think you have answered that. And yeah, can I give the mesenchymal stem cells after 2 weeks of therapy?
I would like to confess one thing. I don't have a huge first-hand experience of using mesenchymal stem cells for COVID-19 infection, but extrapolating our experience in allogenic stem cell transplant, allogenic bone marrow transplant, it has a promise of some efficacy in our severely infected COVID-19 patients.
Yeah, there are questions related like, can we use it after 2 weeks of illness?
Absolutely. Those patients, the earlier the use, the rapidly deteriorating or the clinical parameters not improving despite all the therapeutic interventions, these are the patients which can be taken for mesenchymal stem cell therapy.
Okay, I think we had actually an interesting interactive session. What we can actually take home from Dr. Ganesh is it is an investigational therapy which has been trialed over the last year or so. And like many other investigational therapies, as we have seen the roller coaster ride of even the other supportive therapies, including the steroids, which actually said yes, no, and again, now we are using it as one of the important first line therapy in moderate to severe cases. And the experience on direct hands-on experience has been still limited with us also. Dr. Ganesh is trying to procure the stem cells therapy for a few of our patients whose families are interested to start, because many of our clinicians are getting queries from the families, from their relatives, from their so-called Western country links and clinicians who are questioning us whether we can use a stem cell therapy in them. So to understand that, we theoretically have a logic, we theoretically have a hypothetical concept that it may downregulate the inflammatory phenomenon and upregulate the healing process and probably recover back the particularly the pulmonary function and probably help us in these cases. We need probably further direct hands-on clinical experience with the use of them. We are planning few for as a pilot analysis or a pilot study or a pivotal analysis in few of our cases, and probably from there we'll get back to the further information in the near future. If we have any queries from others, they can unmute Dr. Misra, Dr. Karan Kumar, or any others, then we can take those points.
Yeah, good evening, everyone. Dr. Misra here. Dr. Ganesh, it was a really great presentation. Actually, I've enjoyed the whole session till now. Coming back to the basic things, apart from the stem cells, one thing I just want to ask, sir. Actually, do you believe like unfractionated heparin will be a better choice over low molecular heparin when it comes to the basic COVID patient where the D dimers is significantly high? Let's see, more than 3,000, 5,000. What we have seen in our experience is whenever we are using unfractionated heparin as an infusion, their D dimer levels are coming down in a better way than even if we are giving the therapeutic dose of low molecular heparin. Is there any correlation you can have, like why and how? Can we answer it?
Sir, as per the recommendations across various societies like American Society of Hematology, ISTH, so both unfractionated and low molecular weight heparin work similar way and their efficacy is equal. Only difference as per the societies is the creatinine clearance. Those having creatinine clearance less than 30 ml per minute, there we avoid fixed dose low molecular weight heparin. There we titrate the unfractionated heparin dose because it can be rapidly reversed if it is over anticoagulation. Barring that, the experience of better thromboprophylaxis with UFH compared to low molecular weight heparin probably is not documented across the literature, and based on that, the recommendations are for both. But this is an important observation, sir. So I think we can see what are the other parameters because of which the UFH is working better in terms of bringing down D dimer early. But the both ways by the same mechanism. So essentially, their efficacy endpoint should be similar. There shouldn't be theoretically any difference with regard to D dimer normalization or downtrend of D dimer with any of these. But it is an important observation.
I fully
Look
agree.
into the various variables causing
That's what.
such difference.
Yeah, I fully agree with you, sir. Theoretically, low molecular weight heparin and unfractionated heparin both should work in a similar way, but somehow in our observation, and right now all of our like clinicians also they are following the same. If the D dimer is too high, we are starting off unfractionated heparin infusion in place of low molecular heparin in the therapeutic dose. Anyway, maybe we need to see more. The same thing we have seen in the last and like last year also.
Yes.
A few more things I just want to ask, sir. Let's see. Undoubtedly, there is a significant hematological thing which is going on in COVID. Let it be microvascular thrombosis or whatever. So we are seeing a lot of cases coming down now post-COVID with having multiple arterial thrombosis, like having ischemia. They are requiring vascular revascularization, and all those things are going on. We have 2-3 cases right now. So, but that part is like just want to ask one thing, sir. There are multiple drugs which has been like one after one is coming out. Like let it be tocilizumab, or let it be bevacizumab, or maybe this one like tofacitinib. They are all like mostly they are used either in some rheumatoid arthritis or some form of your hematological condition only. As per your experience in hematological conditions, where you believe like IL-6 inhibitor or Echinra, which is IL-1 inhibitor, or this is like VEGF inhibitors, this rheumatoid arthritis drug like tofacitinib, which should act better in this COVID patients, where we should hit?
Sir, as such, there is no direct 1:1 comparison across various anti-inflammatory molecules like tocilizumab, abciximab, and all these molecules. But yes, the COVID manifestations, the severe COVID manifestations, in a way mimic something called as HLH, hemophagocytic lymphohistiocytosis in hematology, or macrophage activation syndrome in autoimmune disorder. So rather than the COVID virus taking the toll or causing the major ill effects on the body, it is the human anti-inflammatory cascade, or what you call it as cytokine storm, that is detrimental. That uncontrolled cytokine storm, uncontrolled inflammatory response to the viral infection is the cause for the deterioration. And that's how the rationale of using all these anti-inflammatory molecules, right from steroids, IL-6 inhibitors, IL-1 inhibitors, anti-VEGF molecules. Of course, there is no randomized control trial 1:1 proving one molecule's superiority against other, but yes, tocilizumab is quite quite widely used across IL-6 in monoclonal antibody. So, and the FDA initially has approved fast track approval for tocilizumab, but then on one hand, you are dampening the inflammatory cascade and the various opportunistic infections merging and causing further deterioration of these patients. This is something to note about. But looking at the various molecules and the literature evidence, all seems to be working. And there is no evidence as of today that one particular molecule is superior to other molecule. And yes, the most commonly used molecule across is number one, steroids, and it has been proven undoubtedly that it is the one of the most definitive interventions improving outcomes across moderate to severe COVID-19 infections. Second one is tocilizumab. There are pros and cons for tocilizumab because it completely aborts all the inflammatory markers and all the inflammatory molecules, leading to various opportunistic infections that may take a further toll in these cases.
Yes, I think that controversy goes on and the choice also goes on, and we now have no choices, no options available. Sometimes you left with the stock out, you choose maybe one, but you have options with a few. So there are some interesting questions being this, as you said, thromboinflammation, coagulation cascade dearrangement. We, even though commonly see thrombocytosis in the early part of the COVID, but later on we see some thrombocytopenia with rising D-dimer, more than 10,000, and you start dipping your thrombocytes. So again, we are talking about giving anticoagulation in them. We work up with fibrinogen. Initially, as you said, we see hyperfibrinogenemia, then later we see the fibrinogen dipping down. We also spoke about PT variations, APTT variation, factor 8 getting involved in this. So there are many things going on. But the simpler question here is, what anticoagulation do we use there? And should we continue the anticoagulation in spite of being the thrombocytes dipping down? And what will be the cutoff? Is it 1 lakh? Is it 70,000? Is it 50,000?
So normally for continuation of prophylactic or therapeutic anticoagulation, the platelet count threshold is 50,000. So if somebody has a platelet count between 25 to 50,000 and no active bleeding, you can transfuse platelets to keep platelet count above 50,000 to continue anticoagulation, either therapeutic or prophylactic based on the level of illness. And those with platelet count less than 25,000 with active bleeding, these are the patients you need to titrate the bleeding versus the thrombotic, prothrombotic tendency in these patients. One of the peculiar feature of COVID-19 infection is that it causes macrovascular thrombosis, which is clinically overt. As I showed in one of the studies, in one of the French studies, you look for it, you will find it. 70% of their ICU hospitalized patients have overt thrombosis when they actually did investigations as routinely to look for it. At the same time, apart from the macrovascular thrombosis, severe COVID infection has also, in fact, the root cause of all the worsening organ function, most notably the worsening respiratory failure, is extensive microthrombi, thrombotic microangiopathy, involving capillaries, venules, and microvasculature. That is the cause for end organ dysfunction. And that's why the anticoagulation, based on the extent of involvement, severity of illness, is devised, the intensity, the duration is devised. So with regard to the anticoagulation of choice, most of the patients in-house, during hospitalization, they receive anticoagulation with low molecular weight heparin, 1 to 2 milligram per kg based on the severity of illness. Again, which is at the time of discharge overlapped with direct oral anticoagulation. Anticoagulant most widely studied is apixaban. Of course, there are studies of dabigatran and other molecules.
Yeah, just one point in your slides, you projected that if your D-dimer is more than 3,000 and you have intermediate dosing of anticoagulation during your stay as a illness of COVID, you wrote your anticoagulation need to be continued for 4 to 6 weeks.
Yes, sir.
Whereas a proven case, you said it's 3 months.
Yes,
so
sir.
4 to 6 weeks in a D-dimer of 3000 without a proven DVT in our clinical practice is too long, because as you rightly mentioned in your next slides that it will be varying between 7 days to 45 days.
Yes.
Most of the times in moderate diseases without proven DVT, we just continued for a week or two, then we drop. So
Correct.
what is your comment on that?
Sir, so the level of illness, level 1, 2, 3. So intermediate illness is where they have recommended 2 to 6 weeks of anticoagulation. Okay. Probably saving 1 out of 100 lives is very, very crucial. I have a patient currently in our hospital, 33-year young gentleman without comorbidities, severe COVID illness, at discharge, discontinued anticoagulation after 10 days, came up with extensive arteriovenous thrombosis involving both the legs. And he actually presented with extensive gangrene of both the legs. Actually, he needed above knee amputation at the age of 33 years. So I feel this thrombosis and the post, of course, across various studies, the post-discharge thrombotic episodes are not so high as during hospitalization and during the active phase of illness. Like the literature documented episodes are somewhere between 5 to 10 per 1,000 hospital discharges, which is not different from the routine ICU discharges, little 2 to 3 times higher than the routine ICU discharges, non-COVID ICU discharges. But yes, there are patients who present with extensive arteriovenous thrombi, and that is the reason why the recommendations across various guidelines, across various societies do vary. And I found this Emory University recommendations to be reasonably useful for our subset of patients based on their extensive patient database.
Okay. With the limitation of the time, I think we thank Dr. Ganesh in bringing out some interesting interaction and enlightening all of us. I think we thank all the participants for their comments.
So 2 minutes, sir. Just have one.
Yeah, Karuna Kumar, go ahead.
Dr. Ganesh, thanks for the nice presentation. See, I think we should use a mesenchymal stem cell therapy rather than transplant. That's
that is a misnomer. So it is, people believe transplant. So I don't want to, leave behind the wrong message here. So mesenchymal stem cell therapy is being used experimentally across various neuro, cardio, various organ degenerative diseases, which is still experimental. But yes, here in these desperate circumstances, just like bone marrow transplant, it has a possible promise, potential therapeutic promise. So that's why rather than carrying away the, delivering the message that stem cell therapy useful across different experimental groups, I intentionally put it as transplant.
Yeah, that is one point. And second thing is, before we use this therapy in the patients, we should have a research board, and we should have ethical approval. There is a lot of procedures. I think we should not randomly try in patients, and then there is a process of research committee. I think
ideally institutional review board ethic committee approval should be taken, because these are all experimental therapies, and as a whole, IRB, institutional review board approval will be something which will be beneficial for all of us, caregivers.
Yeah, this is a very important point to be taken. That's my last query, sir.
Thank you for those inputs, Dr. Karan. So with this, I think we come to the end of this wonderful session. I thank all the participants, and we conclude the session. Thank you, Dr.
Thank you so much, sir. And I end here by appealing everybody to keep safe and wishing everybody good health throughout this unprecedented time. Thank you.
Stay safe. Thank you.